Guys, in this video I am going to talk about carcinoma of esophagus. So first let's talk about some basic features and epidemiology part. All the cancers of GIT are more common in male than female except for the gallbladder, which is just common more in females. So this is carcinoma of esophagus, so more common in males than females and generally more than 55 years of age. Now we know that in esophagus it is mostly the squamous cells and the lower 1 centimeter part is only the columnar cells. So most commonly the upper 2/3 cancers are gonna be the squamous cell carcinoma and the lower 1/3 cancer, that is due to the Barrett's esophagus, which is intestinal metaplasia in which squamous cells are going to turn into the columnar cells of the intestine of type. So there the lower 1/3 part adenocarcinoma is most common, and adenocarcinoma is generally more common in the western countries in mostly white males. So let's see this one. I have no space to write this down, so I am just writing it here. So upper 2/3 cancers are squamous one, and from this the most common site is middle 1/3, while the lower 2/3 1/3 is adenocarcinoma, and that is mostly seen in white males. And overall the most common type of cancer is squamous one, and the most common site we know that it is middle 1/3. So we know that most common cancer is the squamous one overall in the world, and most common site is middle 1/3. But if we talk about in the western country, it is adenocarcinoma and mostly in the white males. Now we have to learn about the risk factors. So for all GIT cancers there are 3 risk factors that is all common: vitamin C deficiency, nitrosamine containing smoky foods, and smoking. So these 3, smoked, nitrosamine compound, vitamin C deficiency and smoking, these 3 are just common for all the cancers. You can include alcohol also. So let's see. So vitamin C deficiency, hot beverage you can include smoked fish, nitrosamine compounds and alcohol and smoking. Now there are some conditions we have learned previously, that is pre-malignant conditions, so it will increase the risk of esophageal cancer. What is that? We have learned in Zenker's diverticulum risk is 0.5%, Plummer-Wilson syndrome risk is 2 to 3%, and achalasia cardia the risk is 10%. And Barrett's esophagus is a risk factor for adenocarcinoma. And first we will learning about the squamous cell carcinoma. The risk factor is for squamous cell carcinoma here. So here it will don't include the Barrett esophagus, and a special is also the alkali stricture, that is liquefactive injury, can also give rise to squamous cell carcinoma. Now one thing that you can forget is HPV. So in HPV there are some types that is more commonly involved, that is 16, 18, 31 and 33. You can remember it. That is the same for the carcinoma cervix, so it won't be a problem. Now the familial conditions. Also there is a condition called as geotrichum candidiasis, also a risk factor. Geotrichum candidiasis. Slightly extra, if you want to remember, then you can remember this. Now a familial condition, there is a syndrome called as Howell-Evans syndrome, also known as tylosis. So typhlitis, I have often confused it. Typhlitis is neutropenic due to neutropenia and inflammation of generally cecum, and here it is tylosis. So I know, totally different condition. Mostly I don't think anyone will confuse this, but on a safer side I am telling about myself. So Howell, it is slightly more darker, I think, but we have to remember this, so I am just putting a more highlighter, more intense highlighter. So Howell-Evans syndrome, that is tylosis. So gene name is simple. You can remember that tylosis causes esophageal carcinoma. The name we can remember by this. And chromosome, you don't have to remember this. I mean, we have to remember a lot of chromosome. This one is not that much important. It is autosomal dominant condition, TEC gene, and 70 to 80% risk of carcinoma will be there, plus hyperkeratosis of palm and sole. This is an important thing. Howell-Evans syndrome causes hyperkeratosis of the palm and soles. And I think we will also learn this in gastric carcinoma, that there is also, I think, hyperkeratosis of palm and soles, but I am not sure. So let's see. I am also going to make a video about gastric carcinoma, so let's remember the fact as of now. Second is Fanconi anemia and Bloom syndrome. So how can remember Howell-Evans and Bloom syndrome? Where do we have learned this Bloom syndrome? I got this data that Bloom syndrome I have learned, and I have to search about this. I have learned this Bloom syndrome recently, I just forgot it. Yes, I have learned this from the biochemistry. I think there was I'm just forgetting all the things. So Bloom syndrome is an inherited disorder characterized by short stature or skin rash that develop after exposure to the sun. I just don't. Shorter than average height, narrow face and a red skin. What is, yes, enzyme defect. Yes, I think it was a helicase enzyme. Helicase enzyme. So this Bloom, Fanconi and Havel-Evan syndrome, these three things we have to remember in the esophageal carcinoma. Fanconi anemia is Fanconi syndrome, and Fanconi anemia is a rare which passed down through the families that mainly affects the bone marrow. This decreased production of all types of blood cells. This is the most common inherited form of aplastic anemia, a rare kidney disorder. So what is a Fanconi syndrome? A rare genetic disorder that causes gradual bone marrow failure. Normally symptoms occur at birth or only in childhood. Some physical symptoms may be cafe, woolly spot and curved spine, abnormality in body parts. But why is it happening? What is the cause of Fanconi anemia? Changes in the certain gene exported from 30 different this disease occurs when there is a mutation in one of these 23 genes from the parents. So physical malformation, hematopoietic abnormalities and increased risk of solid tumors in adulthood. So these three things: solid tumor risk increase, hematopoietic abnormalities, that's why it is causing aplastic anemia, and physical, yes, I think it was physical malformation. So this name we can remember that all are blue, means kind of reminding of any flower is blooming. Fanconi means reminder of fountain, and Havel-Evan, so looks like all the people are Havel jolly bodies, very happy. So this kind of reminding you a garden, I think you can remember in that way. I don't know what else we have to remember. Now for adenocarcinoma, I have told you that it is Barrett's esophagus, obesity and fatty food and smoking. These three things. And Barrett's is 10% increasing risk, so 40 times. No, it was just 40 times only. Here it was 10% in echinacea cardia, mixing things up very badly. Now this too we have to remember, obesity and fatty food. We know that adenocarcinoma is more common in Western world, and Western world obesity and fatty food is increasing in very high rate, and also smoking. So we can remember by this thing. So now we have completed the risk factors. I am going to talk about the presentation part. So let's see. So how a patient of esophageal carcinoma is presenting. Let's try a different color. Okay, so presentation. General features, we know that in all malignancy there will be anorexia, weight loss and weakness, cachexia and anemia. Local symptoms, this was general features. Now local symptoms, dysphagia, but it will be very late. We have learned that esophagus has this spiral muscle pattern and it will distend enormously. So this dysphagia will be later part of the presentation, and it will start with solid and then progress to liquid, contradictory to echinacea cardia, where it will be more to liquid in the initial stage and then it will lead to solid progressive. Now we have learned it will be a late feature. And for this 70% of lumen should be blocked to cause any symptoms, and due to distensibility, due to helicoid pattern, it will be a late feature. We know this now. Metastasis will be more than nodes than blood wound. So upper 2/3 will goes more to the lungs, because we know that the blood supply is from bronchial artery, and yes, the lower 1/3 will be liver. Adenosquamous. Now what are the paraneoplastic syndrome? Increase in calcium. Investigation of choice, and first investigation should be endoscopy plus biopsy. For staging, that is TNM, we want to know about the tumor size, depth of invasion. Then we will do endoscopic ultrasound, that is mainly for TNN, for node and depth size of the tumor. But if we want to learn about the metastasis, we will do PET scan more than CT scan. And for USG, we know that frequency is inversely proportional to the penetration and directly proportional to the resolution. So we will do in range of 5 to 30 megahertz, in USG, but here we will do 12 to 20 megahertz. And the PET scan, 18 FDG PET scan is the best one. FDG means fluorodeoxyglucose, and half-life is 110 minutes, so we have to do fast. We can do barium studies. It will show the filling defect, which is mainly irregular, and shouldering will be there. So apple core deformity and red tail appearance. Now for the treatment part, it depends upon the location actually. So cervical, we will do radio plus or minus chemo. For thoracic and abdominal, have to do surgery followed by radio plus chemo. So neoadjuvant or adjuvant. Neo means we are giving before surgery to decrease the size, and adjuvant means after the surgery to decrease the recurrency. If the tumor is from later stage like T3, T4, then we will do neoadjuvant. T2 and 1 staging we will do adjuvant therapy. Now in chemotherapy, for GIT it is mainly cisplatin plus 5-fluorouracil. Vomiting is the main side effect, and severe side effect here will be nephrotoxicity and acute tubular necrosis. So we have to first hydrate the patient and give mannitol. It is also neurotoxic, ototoxic. So nephrotoxic, neurotoxic and ototoxic. This I am talking about the cisplatin. For adenocarcinoma, we are generally just giving 5-fluorouracil. And here there are 3 types. That we have to learn about. So first, it is not the SRI but submucosal resection, only possible when less than 2 cm in size, and it is in submucous plane only, hasn't crossed the muscle layer. So stage T1S, carcinoma in situ. Now Ivor-Lewis esophagectomy, McEwan and Orianger. Ivor, Mac, Orianger. So it is in alphabetical order. Here we are doing for lower 70 to 80% removal, and generally done for middle 1/3, more than lower 1/3. First we will do laparotomy. And second we will do thoracotomy. So first we will do laparotomy, cut it out the lower part, and we have to safe margin check. In esophagus it is 10 centimeter, guys, and in stomach I haven't seen such a long safety margin in any other cancer. And gastric pull up we will do then, and anastomosis by thoracotomy. And most common cause of mortality will be anastomotic leak. Now we will see the McEwan type. Here we will do the total esophagectomy. So first we will do thoracotomy, then laparotomy, and then left neck thoracotomy. So we are generally doing for the upper 1/3 more than middle 1/3. Now for the orianger, here also total esophagectomy, preferred for lower 1/3 more than middle 1/3. So here only same, but first laparotomy and then left neck. Here there will be no thoracotomy. So least lung compliance, but here it will be increased bleeding and increased leak. If it is way too much metastasis, then main aim is to increase quality of life. So best statement for dysphagia is endoluminal stenting. There are some self-expanding metallic tube, MB tube that are now obsolete, and the side effect will be occlusion can happen. Other pain, migration and GERD. Survival 5 year is only 20 to 25%. So we are done with this carcinoma of esophagus. So quickly seeing the presentation. General feature, we know that anorexia, cachexia, weight loss, weakness, anemia, local symptoms, there will be dysphagia, but it will be very late feature. Due to the spiral muscle, it will cause enormous distance stability, and only the 70% of the lumen is occluded, then only the symptoms will start. So the prognosis is very poor, and start with the solid, then liquid, and it will be progressive. Now metastasis is in nodes most common, then bloodborne, and if upper 2/3, then it will be more common in lung, lower 1/3 it is in liver. It is self-explanatory, no need to remember this. Paraneoplastic syndrome is hypercalcemia. Investigation. So investigation of choice is always in cancer. If possible, then we will do the biopsy, so endoscopy and biopsy. For staging, if we have to see the tumor size and invasion of depth and nodes and endoscopic USG, but for metastasis PET scan, that is 18 fluorodeoxyglucose, half-life is 110 minute, and USG we are 12 to 20 megahertz frequency is using, and in barium sulfate we can see apple core deformity and the red tail appearance. Now for the treatment part, the surgery we can do for thoracic and abdominal involvement, not for the cervical involvement generally. Here we will only do the radio and chemo. And chemotherapy, we are preferring cisplatin plus 5-fluorouracil. Cisplatin, we will know that it is highly emetogenic and nephrotoxic, neurotoxic and ototoxic. And for preventing the nephrotoxicity, that is acute tubular necrosis, first we will do the hydration and then mannitol will be given. And we can also do the radiotherapy. Both we can use neoadjuvant or adjuvant. For higher stages we are using as a neoadjuvant, and for lower staging we are using as a adjuvant. Now for the surgery, important part, that submucosal resection less than 2 centimeter, and invasion should be up to submucosal. So stage T1 and T in situ. Now 3, Ivor Lewis, McLeod and Orianger. First is Ivor Lewis is generally done for lower 70 to 80% only, and this two total. Now here it is middle 1/3, here upper 1/3, and for lower 1/3, I don't think it was lower. Wait, let me see. Yes, it is for lower 1/3. So we are preferring this for lower, upper and middle. This we have to remember like anything. Now what are the steps? So for removing lower, first you do the laparotomy, remove the part, and then we have to do the gastric pull up and anastomosis in the thorax. And we have to, safety margin is very large, 10 centimeter in esophagus and 5 centimeter in the stomach. And most common cause of mortality is anastomotic leak. Now in McLeod we are removing the entire esophagus, so thoracotomy, laparotomy, and then we are anastomosising in the left neck. And here we aren't doing the thoracotomy, only laparotomy and anastomosis in the left neck. So least lung complex but increased risk of bleeding and leak. Now in palliation we are doing stenting, so self-expanding metallic tube is most preferred, and the side effect can be pain, migration, GERD and occlusion can happen, and it is a poor prognostic cancer. So cervical rate 5-year rate is only 20 to 25%.